So the whole idea in this session, remember this is a live interactive online session. So the main difference that will happen in this is you will have a commitment to complete. You'll be engaged. You'll have to proactively answer what I'm saying, what I'm asking you, and the retention will be much better in an online live session, right? So see that you utilize it to that full potential. Keep interacting. I'll show you different images. We'll discuss a lot of, topics, concepts, and the whole idea is by the end of the session, you should feel confident to be able to, understand how to interpret cardiac imaging and also have a understanding of which investigation or which modalities to use for your patient care, right? So let's get started with the very first one. First, what do you mean by plethora? Let's get started. Yes, give me a quick yes and quick thumbs up, and we'll get started. If all of you are settled, right? Yes, sure. Let's get started. Fine. The first one is, what do you mean by plethora? The plethora basically is an area where you have increased pulmonary arterial marking. So if you have increased pulmonary arterial marking, that area is called as a plethora. Right? On the chest radiograph, if you see more pulmonary arterial markings, that is a plethora. So if I ask you that, imagine the pulmonary artery in a patient is originating from the left ventricle. Imagine a condition. Normally, pulmonary artery comes from right ventricle. But imagine the pulmonary artery is coming from left ventricle. Like that happens in transposition of great arteries, right? We have a congenital cyanotic heart disease, the transposition of great arteries, where the pulmonary artery comes from left ventricle. What do you think will happen to the pulmonary arterial flow? Will it be more or less? Do you think there will be more flow in the pulmonary artery or less flow in the pulmonary artery? What do you think will happen? More flow or less flow? Obviously more flow, right? So obviously left ventricle is a high pressure chamber, so you'll have more pressure, more flow into the pulmonary artery. So you'll have increased pulmonary arterial marking. So whenever you have the transposition of great arteries, or whenever the pulmonary artery is receiving the blood from the left ventricle, you expect plethora on the chest X-ray, right? So you'll have plethora on chest X-ray. Is this okay? This is clear. Next, oligemia. Now let us understand oligemia. Oligemia is basically decreased pulmonary arterial marking. Increased pulmonary arterial marking is plethora. Decreased pulmonary arterial marking on the chest radiograph is called as oligemia on chest X-ray. So imagine if there is pulmonary stenosis, if the pulmonary artery is showing stenosis, if there is pulmonary stenosis, as it happens in tetralogy of Fallot. You know tetralogy of Fallot? You have pulmonary stenosis. One of the important things that happens in tetralogy of Fallot is pulmonary stenosis. So if you have pulmonary stenosis, what do you think will happen to the radiograph? Will it show plethora on the chest radiograph or oligemia on chest radiograph? Will there be more flow or less flow? Obviously, there'll be less flow. That is called as oligemia on chest X-ray. Oligemia on chest X-ray. So plethora is increased pulmonary arterial marking. Oligemia is decreased pulmonary arterial marking. Transposition of great arteries will lead to plethora on chest X-ray. Tetralogy of Fallot, which has pulmonary stenosis, will lead to oligemia on chest X-ray. Now look at the chest radiograph and you tell me, look at this first radiograph and please tell me, how do you see the pulmonary vessels in the lung fields? Do you think is it more or is it less? Do you want to call this first radiograph as a radiograph showing plethora or is it showing oligemia? Can you just tell me, is it showing plethora or is it showing oligemia on chest X-ray? Very good. This is showing you plethora on the chest X-ray. This is plethora on chest X-ray. Very good. Very good. Nice. Okay. Sarang, Sajil, Vishal, Anjali, Nitya, Sharvari, right? Nancy. Good. Plethora. Now look at the next radiograph. On the next radiograph, look at the lung fields and tell me, are you seeing plethora or oligemia on the chest X-ray? Are you seeing plethora or oligemia on the chest X-ray? This is oligemia on chest X-ray. So this is showing you oligemia on chest X-ray. Right? So this is oligemia on chest X-ray. So whenever we have increased pulmonary arterial marking, that is plethora. When you have decreased pulmonary arterial marking, that is oligemia on chest X-ray. I hope this is clear. Now let's try to understand that if tomorrow you are having a patient who is a newborn and is having cyanosis and plethora on a chest radiograph. You're having a newborn with cyanosis and plethora on chest X-ray. What comes to your mind? newborn with cyanosis, and plethora on chest X-ray. What is coming to your mind? Very good. Please remember, because you're having a newborn with cyanosis, this is not tetralogy of Fallot. Tetralogy of Fallot is a child with cyanosis. Newborn with cyanosis is transposition of great arteries. Very nice. This is transposition of great arteries. Transposition of great arteries. And just now we learned that in TGA, that is transposition of great arteries, you will see plethora on the chest radiograph, plethora on chest X-ray. I hope all of you have received the workbook also. All of you have received the workbook. Please keep filling with the workbook. I'll add few extra points towards the end of the session. I hope you have received the workbook also, right? Fine. So newborn with cyanosis, plethora on chest X-ray. This is transposition of great arteries. Child with cyanosis with oligemia on chest X-ray would be tetralogy of Fallot. Child with cyanosis with oligemia on chest X-ray would be tetralogy of Fallot. Newborn with cyanosis with plethora on chest X-ray is transposition of great arteries. Now, if you look at the transposition of great arteries, now imagine this is the arch of aorta. This is the pulmonary artery. This is how the normal superior mediastinum is. You see the aorta coming from the left ventricle and the pulmonary artery coming from the right ventricle. This is how the normal mediastinum will appear. This is normal appearance. But in case of transposition of great arteries, the pulmonary artery is coming from the left ventricle. The pulmonary artery is coming from left ventricle. Left ventricle has high pressure, high contractility, right? Lot of blood is ejected into the pulmonary artery. So you'll have plethora. But if you see the aorta is arranged parallelly, anterior and to the right. So if you're given on fetal a cyanotic heart disease, on a fetal echocardiography, there is parallel arrangement of aorta and pulmonary artery. If there is a parallel arrangement of aorta and pulmonary artery, which condition are you going to think of? There is a parallel arrangement of aorta and pulmonary artery. The aorta is coming anteriorly and to the right of the pulmonary artery. This is what is transposition of great arteries. Transposition of great arteries. Please remember, a parallel arrangement of the aorta and pulmonary artery on fetal echocardiography. This is transposition of great arteries. So what will happen to the mediastinum? Will the mediastinum will be wide or narrower? What do you think will happen to the mediastinum? It will be a narrow mediastinum. There will be a narrow superior mediastinum. This narrow superior mediastinum has been compared to a string. This has been compared to a string. And the heart is the egg. The heart is the egg. And this appearance on chest X-ray, where you have a narrow superior mediastinum, you can see the image here. You can see a narrow superior mediastinum and the heart is compared to the egg. This is called as egg on string appearance or egg on side appearance on the chest radiograph. This is suggestive of transposition of great arteries. So I want you to first understand the chest X-ray findings. The first topic that we are doing is how to look at the chest X-ray findings and how not to confuse with the modalities. It is very easy to just give you a table. Transposition of great arteries is showing you egg on string appearance, but this will get confused as you learn a lot of topics. But if you understand the concept, it will stick with you. A parallel arrangement of aorta and pulmonary artery. The patient having a narrow superior mediastinum and egg on string appearance. Plethora on chest X-ray, because the pulmonary artery is coming from left ventricle, you will have plethora on chest X-ray. All of this is classic transposition of great arteries. Transposition of great arteries. Are you all clear with this concept? All of you are clear? One thing I want you to understand or make a note is a parallel arrangement of aorta or pulmonary artery. And transposition of great arteries. Transposition of great arteries. This is common in children born to diabetic mothers. So in diabetic mothers also, if you're given a clue of a diabetic mother, the child also has risk of developing this transposition of great arteries. Keep this in mind. Next, do not get confused with egg on side with egg in cup appearance. Egg on side appearance and egg in cup appearance. What do you understand by egg in cup appearance on chest X-ray? Egg in cup appearance on chest X-ray, C4C, remember, is suggestive of pericardial calcifications. So when you see the pericardial calcification, so imagine this is the heart, and if you're seeing the pericardium getting calcified, this appears like a cup. Egg in cup appearance is different. Egg on string appearance is different. Egg on string appearance is transposition of great arteries. Egg in cup appearance is pericardial calcification seen in constrictive pericarditis. This is constrictive pericarditis. So you can remember CCC, all of this is constrictive pericarditis, constrictive pericarditis. Now, can you tell me what are the causes of constrictive pericarditis? When do you think you'll have this egg in cup appearance or a constrictive pericarditis? It can occur idiopathic. It can also occur after radiotherapy. After radiotherapy. It can occur in patients with TB, in tuberculosis patients. Consider the pericardial calcifications can develop. Can also occur in CKD patients, uremia patients. These are important causes for pericardial calcifications. So pericardial calcifications, when you have, this gives the appearance of an egg in cup appearance on chest X-ray. Are you okay with this first page, all of you? All of you can manage this first page? This is clear. Plethora, oligemia, how to look on the radiograph, what is TGA, and what is this egg in string appearance and egg in cup appearance and egg on string appearance, right? So this is clear. Two things I want you to keep in mind. TGA is commonly seen in children born to diabetic mothers. Also remember the parallel arrangement of aorta and pulmonary artery in patients with transposition of great arteries. The next thing we'll talk about is a very common cyanotic heart disease, that is your tetralogy of Fallot. So you will have a child with cyanosis. And as tetralogy of Fallot shows pulmonary stenosis, these patients will show oligemia on chest X-ray. We discussed this. So when you see a child with cyanosis and oligemia on chest radiograph, this is suggestive of tetralogy of Fallot. Tetralogy of Fallot. Now, before we understand what are the different things in tetralogy of Fallot, the first thing that I want you to concentrate is the embryology. Tetralogy of Fallot is because of malalignment of the aorticopulmonary septum. So it is due to the malalignment of the aorticopulmonary septum. Now try to understand this. I've given you a diagram lower down. Just concentrate on the diagram here. This is a normal development of the heart. This is normal. And this is what is happening in tetralogy of Fallot. Let us see what is happening in the normal heart. There is a primitive ventricle. From the floor of the primitive ventricle, you get a muscular part of interventricular septum. There's a common chamber, the primitive ventricle. From the floor, you get a muscular part of interventricular septum. There is a common vessel called as truncus arteriosus, right? The truncus arteriosus. Truncus arteriosus. And within the truncus arteriosus, you have the formation of the aorticopulmonary septum. This septum is the aorticopulmonary septum. That is dividing the truncus arteriosus into pulmonary artery and the systemic aorta. Pulmonary artery is coming from the right ventricle. Systemic aorta is coming from the left ventricle. And this aorticopulmonary septum, along with a part of the endocardial cushion, is responsible for formation of membranous part of interventricular septum. We are just understanding the normal development of the heart. So from the floor of the primitive ventricle, you develop the muscular part of interventricular septum. The aorticopulmonary septum contributes to the membranous part of the interventricular septum. And what did we learn about tetralogy of Fallot? Tetralogy of Fallot is this malalignment of the aorticopulmonary septum. The aorticopulmonary septum is not coming in the midline, it is malaligned. When the aorticopulmonary septum is malaligned, what is happening to the pulmonary area? Is it normal or stenosed? It gets stenosed, not at the wall, but at the subpulmonic area. So it gets narrowed at the infundibular or subpulmonic area. So you have a subpulmonic pulmonary stenosis. So there is a stenosis below the pulmonary wall. So infundibular pulmonary stenosis or subpulmonic stenosis occurs in tetralogy of Fallot. Now, when you have subpulmonic stenosis, obviously you will have what? Oligemia on chest X-ray. When the aorticopulmonary septum is malaligned, the more the malalignment, the more severity it is, the more amount of pulmonary stenosis it will be. So the severity of tetralogy of Fallot is determined by the amount of pulmonary stenosis. What is determining the severity of tetralogy of Fallot? The amount of pulmonary stenosis. The subpulmonic or the infundibular pulmonary stenosis determines the severity of tetralogy of Fallot.